everyone's heard enough of my speech. So I'm going to say that again. I think we have enough people to go ahead and get started. I know we have a lot of content to cover in this hour. So my name is Crystal Garcia. I'm the training coordinator here at TAASA. Again, I'd like to thank everybody for being here and helping us finish out the year with some really amazing training. So we have a few more next week. Please sign up for those as well. Just a couple housekeeping things before we get started. This webinar is being recorded and it is being processed for our YouTube channel. So pending any technical difficulties, our goal is to have those up by the end of this year. So we have our IT people getting those up on our channel as fast as they can get them edited and ready to go. If you have any questions about training, please contact me at cgarcia@taasa.org. This includes individual trainings for your center as well. Our presenter today is Rebecca Fears from UTHealth Tyler, Texas. She is the forensic nurse coordinator. She's going to be talking to us about HIV, which is still a really important and relevant training when working with survivors and being able to talk to them about this issue in a really medically informed way. So I'm excited to get to it. So I'm going to go ahead and mute myself and turn off my camera because it makes the video run a little better. And I'll turn it over to Rebecca.
You guys hear me? Yeah? Okay. I'm just going to keep talking and pretend that you can. Put something in the chat box if it's not clear. Thank you guys so much for showing up today. I am going to give you a background history on HIV because I realized talking to one of the new nurses, actually what she said was, well, what's the big deal? I mean, you just take the medication and everything's fine. And she just didn't grasp the context of what had happened or didn't have any perspective on the history of it. So we're just going to kind of walk through history a little bit together today. Provided I can make my slide move. You guys may learn something really terrible about me here, that I struggle with technology sometimes.
I think we're all learning new technology stuff right now. So.
Yeah. Any ideas on why my screen won't advance?
Let's try. Do you want to start or try getting out of it and reloading it again? Maybe not.
I did something. Okay. So
thank you, TAASA.
Yeah. So yeah, thank you, TAASA, for letting me put this together and giving me this platform. This is part one of a two-part series. So we're going to cover the why you need to know all this and why it's important today. And hopefully we expand your knowledge of the history of HIV in the United States. I think the biggest antidote to fear is information. So hopefully you feel like you get a lot of information. And maybe it will inspire you to change the way you practice. Maybe not. Maybe you're already doing everything right. One of the things I really wanted to stress is giving a victim the opportunity to start HIV prophylaxis immediately if they're in the 72-hour window. And if they're not sure, or if they have a complicated medical history, to not delay that first dose. Take the first dose now, and then we've got time to think about it. So that's kind of the premise of how I practice, and that's kind of supported in the science. Oh, that's backwards. There we go. All right, so who's here today? I saw a group from Weatherford that does sexual assault and DV together. That sounds exciting. Are there any other healthcare providers on here? Advocacy, law enforcement, primary prevention, campus, student. Thank you for taking the time to figure out how to participate in that. I really appreciate it. So I've got one forensic nurse and one healthcare provider and a whole bunch of advocates, a little bit of law enforcement, a little bit of primary prevention, and I've got a campus. I'm assuming that's a Title IX person or Title X. Clinical therapist, great. SART coordinator, oh, I think SART teams are amazing. All right. Well, thank you. Thank you for doing that. We're going to move on. And I thought we might just take a moment here to blow out all the air in your lungs. Just really, really take a moment and empty your lungs. Crystal, is there a chance you can move that polling apparatus off of my screen? It's right in the center of it. Okay. So this is hard work. It can be very triggering. Be kind to yourself today. And if you notice, I didn't ask you to take a deep breath. For some people with anxiety, they've been told to take a deep breath all their life, and sometimes that can be very triggering to them. And so what if we just tell you to blow all your air out and to really think about that, because the next thing that happens is you do take a deep breath. So that's kind of a cool way to kind of hit that from a different direction. We are here today because of this young man. This is my son. I am a nurse. I am not a doctor. I do not prescribe medications. I talk to patients about their medications and how the safe and effective use of them. And so that's kind of where I'm coming from today. It would be nice if infectious disease physicians did more talks about this, but perhaps it might be best just from those of us at the bedside doing it. We need to go back in time a little bit. We need to think about that there were not cell phones at the beginning of the AIDS epidemic. That bag phone up in the top left corner is years from coming out. Television is something that's a piece of furniture. It's not just something mounted on your wall. There's no remote control. Our telephones are wired to our walls. You have to go down the hallway to answer a phone. It was just kind of a different way. All of our information came to us in paper, in a newspaper, in a textbook. That's how we got information at the beginning of the 80s. We realized that we had a problem. This first report for the Morbidity and Mortality Weekly Report came out June 5th. And we had patients in Los Angeles with pneumocystic pneumonia. And you've probably never heard of that unless you've taken care of AIDS patients, or sarcoma, because if you have a healthy immune system, you should never have these diseases. Back then, we did not call it HIV or AIDS. We called it GRID. It was a gay-related infectious disease. And we really didn't know what it was or what it was doing. We just knew that a couple of people here and there were sick. We saw this in New York, out in Los Angeles, San Francisco. And yeah, so I'm going to use some visual images to talk to you today. And I wanted to borrow from my friends at Tend Academy in Canada. And it's just asking you to take a moment and run it through these 4 things so that you can give a low impact debriefing. Are you aware of what your work is? Do you give a fair warning? And most importantly, and I'm sure my advocates will really love this part, is you get consent. By participating in this, you're giving consent. And you're looking at these images by choice. And then I really did try to limit what I'm showing you, that nothing was violent or graphic. And I'm going to proceed with your assumed consent. This is the first media headline about AIDS. This was July 1981. And it's kind of interesting to look at all of this through the lens of I've almost lived all the way through 2020, and we need more research, not hysteria. So you can kind of hear that echoing today in different ways. 1982, we discovered for the first time that our nation's blood supply was not safe. We have an infant with AIDS, and we're realizing that that came from our blood supply. And we have our first hint that AIDS can be given by perinatal transmission. What that means is that a pregnant mom can give this infection to her baby. And so that was really scary for us to discover. I just kind of did a sampling of different headlines that you might have seen about this time. I really want to call your attention to on the left of your screen where it says AIDS is the wrath of God. I can't tell you how many times some version of that wasn't repeated from the pulpit. So just think about that for a moment. Why would you try to cure something that was sent by God? And think about how that might have influenced everything and the damage that that could have done. We've got our first link to a report from the CDC with recommendations to prevent occupational exposure to healthcare workers. And if you look on the left, we've got a toll-free telephone system where you can call and get information. And I can tell you that now, today, that is something that I still use. That is a service. I'll have that number for you at the end. That is still available, and it's still needed. We still need to have that access. So this is what we did. We told people who work with AIDS patients, people who do our dentists and our morticians. We identified these three groups as being healthcare providers at risk, and we started talking to them about what to do to prevent the spread. And probably every person in the United States today knows of what PPE is, but this was some of our first experiences with that. Last week, while I was putting this together, are there any Blinkist fans out there? This is one of my favorite things to do in the morning because I don't read a lot of nonfiction that isn't work related. So this is a new publication. It's called Deep Fakes. And they started talking about AIDS. And I'm like, well, wait a minute. Why are they talking about AIDS? Because when I thought of fakes and deep fakes and Russian involvement, I thought that was all about election stuff. But they went back to what they're calling in this textbook the first time that Russia became involved. And they owned this newspaper in New Delhi, and they printed this article about AIDS. And they started talking about this being a weapon that the United States created at Fort Detrick, and that it was designed to kill African Americans and gay men. What happened when they published this in New Delhi is that 80 other countries picked up this story and printed it in their newspaper. I apologize for how difficult this is to read. There is an email that you'll get after this where you will have a link to it. This is actually from a library at the University of Illinois. But when I started reading this and trying to sleuth my way through this, I actually remember the story about Fort Detrick. And then I remember when I was overseas having people in other countries ask me about, is it true? And it's like, and that's where this came from. So here's according to the author of the Deep Fakes, here's your first disinformation campaign that was started. This is 1984. Yes, that is the younger me. I joined the military. This is also the first time that we identified needle sharing as being a problem. So kind of like put that in your brain, on your timeline. July 13th, 1984, we knew that needles were a problem, and needles were a way to share the HIV infection. In 2020, fast forward to today, we still have problems opening and running safe injection sites in the United States. It's not something that our culture accepts. This is a picture of one of the first needleless systems that became available years later in the hospital. There's two things about this that make it safe. If you see, it's a plastic blunt tip needle, and at the base of it, there's a place where it screws into the syringe. You don't just stick it on there. You actually have to have the lure lock system. We developed protocols for how to test our blood. The problem back then was how long it took to get test results versus how long the blood could sit on the shelf. So that became something that we started studying. 1986, this was a big year for me. I had my first child. C. Everett Koop is our Surgeon General. This is also when, for me, the military started testing for HIV among active duty and reserve soldiers. So what that meant at that time was that they drew our blood, and 3 months later, we were told we were HIV negative, or 4 or 5, or however long it took, because about 10% of the soldiers were coming back HIV positive, And those soldiers, your commander, your chaplain, a judge advocate staff would come to your home and they would sit down with you because they were going to process you out of the military for conduct unbecoming because you were HIV positive. Unless, of course, you could prove you had had a previous blood transfusion. That meant you were gay, you injected IV drugs, you did something that wasn't good service for our soldiers. So this was a big year. This was scary. It was scary to get your first test, right? In 1987, you see Miss Jolene Connor there. She's telling you to wear a condom and protect yourself. Learn how to protect your families from an HIV infection. 1987. We know that barrier methods in sex prevents HIV. This is from the 2020 CDC website. We still don't have good condom availability. If you look at the bottom of the screen, 7.2% of high schools, 2.3% of middle schools have condoms available for students. But we know that this prevents the spread or works to prevent the spread. I don't know how you teach your adolescents and teenagers to prevent HIV spread. This is the conversation that I had. Where's your cell phone? Because all of these young adults have cell phones. Let me see it. If your cell phone is in a case, then I'm going to ask you, why do you put a case on your cell phone and not use condoms? Because you can buy a new phone. So that's the best I've come up with. If you've got a better way to teach this to adolescents or young adults, please put it in the chat box. Please share it with me. I would love to hear how you initiate that conversation with someone who might not want to listen to what you're trying to teach. Now we're at 1988. A couple of exciting things happened for me. I graduated from nursing school, and our Surgeon General, C. Everett Koop, who is by far my favorite Surgeon General, he sends out this booklet to 107 million American homes. So now my dad is reading a book about AIDS and trying to understand the information that's in there. But this went out to every household. I remember having a conversation with my father about this. We've got in these articles here that we're talking about preventing HIV, and now we're linking it to hepatitis B. And we're developing these things, but we realize that if you don't have an immune system, that you have more incidence of these hepatitis B, TB, and that it's a problem. And how are we going to deal with that? And we start looking at these universal precautions that, oh, maybe you should just wear gloves all the time. And this caught on, and this is a big deal, and this is still used today. Right now, I'm sure everybody on here has heard something about PPEs and PPE supplies. And so on the CDC website in July, they wrote an article on how to optimize the use of them. What I want to share with you is that in 1988, when I graduated, if I wanted a pair of gloves, I had to go open a package for 2 of them. And now every room I go into, every corner I take, every wall I look at in a hospital almost has a dispenser with boxes of these gloves, hundreds of them in a box. So the access to them and the use of them has changed so drastically. This is my favorite slide out of the whole presentation, because we took that idea of universal precautions and PPEs, and now we're applying it to trauma-informed care. Because wouldn't it be wonderful if our hospitals use trauma-informed care for all patients instead of just patients that we identified? And so it's kind of a parallel for how we use universal precautions to prevent diseases. And so this idea and this concept makes me very excited for what we might be able to accomplish in the future. 1989 happens. And this was a very scary year for me. This is not to say that I had a better or worse time than anyone else in the 80s, but I had a needle stick at work while I was 8 months pregnant. And so we talked about in the early 80s about we now know that perinatal transmission is positive. And so now I have to make a decision on what am I going to do with my pregnancy, and how do, if I have HIV, how am I not going to give this to my child? Every single healthcare provider I talked to gave me a different answer for what was the right thing to do. In the end, I was using a midwife, and I stayed with my midwife for care, but it was really scary. I was being tested. I was tested the day of the needle stick in September of 1989. I was tested again a month later, 3 months, 6 months, 12 months, and then I began annual testing. So pandemonium erupted for me after that needle stick. This is July 27th of the fall of 1985, and pandemonium erupts everywhere because we have a dentist and a patient, and we believe that this patient is now HIV positive and got it from his healthcare provider. And so that scared everybody. The CDC the next year comes out with recommendations for what does it mean if you're a healthcare provider and you're HIV positive. Please notice with this slide, she's also wearing gloves to give an injection, which is routine what you see now. That wasn't routine when I first graduated from nursing school. If you look up there on the top left, now a lot of these slides are going to be very busy. Please do not think that you have to read everything on there. You will have a link to this timeline.
And I believe maybe everyone, are we sharing those results? Are they able to see?
I'm sorry, I couldn't hear that clearly.
They should be able to see, yes. Okay. All right, we can go ahead and end that polling question. Thank you for your responses.
Rebecca, you're accidentally on mute. Will you mind unmuting yourself again?
Am I unmuted now? Yeah. Okay.
Much better.
Yay. All right, let me go. Okay, so in 1992, what I want to make sure I say to you is that AIDS became the #1 cause of death in the United States for men 25 to 44. So that had that affected everybody. Everybody was heard about that. There's a couple of different timelines that I used. I thought this was very ironic. In 1992, also, we thought we would have the International AIDS Conference here in the United States, and we were unable to because of a travel ban and had to move it back to Amsterdam. Also, there's a comment on this timeline about Ricky Ray. This was a 15-year-old hemophiliac, which means that he routinely used blood and blood products. He had become HIV positive, and the local residents burned his house down. So much was the fear that was going on right then. In 1993, somebody had this really good idea that we need to do planning for this at the community level. And of course, everybody involved with TAASA understands what a community coalition can accomplish and why that was so important. But we decided we would take that to AIDS. Now I'm going to stop here for a second and show you a video.
In an era when much of America turned a blind eye to the AIDS epidemic's devastation, cinema provided a beacon of hope for those who needed it most.
Aren't you the entertainer? Why don't you organize something?
Well, look at you, being all useful. And
on this IMD Brief, we'll download the history of the first movies to raise our collective awareness of HIV/AIDS. In the early 1980s, as Washington and the White House refused to acknowledge those suffering and dying, activists in the gay community fight to be heard. By 1985, the tides begin to change as Rock Hudson, a movie star of Hollywood's golden age, confirms that he has the disease. He dies just a few short months later in October. That same year, queer filmmaker Arthur J. Bresson Jr., who had been making gay-themed films since the late 1960s, writes and directs Buddies, about a friendship between a man dying of AIDS and the volunteer assigned to his bedside. Low budget and only screening at a handful of art theaters and festivals, it's the first film to address the pandemic head on.
Why should I want the world to see me? Well, it'd be hiding.
But it's November 1985's An Early Frost that brings the issue into American homes. An NBC TV movie starring Aidan Quinn, Gina Rollins, and Ben Gazzara, An Early Frost attempts to dispel misconceptions about AIDS communicability in a pointed scene that depicts Quinn's Michael trying to show his mother affection.
That's right, Mom. You might catch it just by looking at me.
1986's Parting Glances stars Steve Buscemi in a day-in-the-life look at a gay New Yorker who has the disease but keeps his acerbic sense of humor. While 1989's Longtime Companion opens with the New York Times' first article about what was then being referred to as the gay cancer. Then follows Campbell Scott, Dermot Mulroney, Bruce Davison, and Mary Louise Parker over the course of that first painful decade of the pandemic.
Welcome to Living with AIDS.
Two landmark documentaries are also released in 1989. Best Doc Oscar winner Common Threads, about the AIDS Memorial Quilt, and the experimentally poetic Tongues Untied, about the often ignored issues that Black gay men face in this new era.
We are now entering the fifth dimension of our sexual consciousness.
1993 is another watershed year. First, HBO's And the Band Played On turns Randy Schultz's book that chronicles the early AIDS epidemic into a docudrama with Matthew Modine and Ian McKellen. Then, filmmaker Derek Jarman dives inward for Blue, an art house exploration of his own experiences with the disease that left him blind to all colors except shades of blue.
Oh, blue, come forth.
As it happened with so many of these artists, the success could not be long enjoyed, and Jarman dies just months after his film premieres. Then comes Jonathan Demme's Philadelphia, the Tom Hanks and Denzel Washington legal drama that wins 2 Academy Awards in 1994, including Best Actor for Hanks, and grosses over $200 million, escalating to a worldwide audience the sad truths of AIDS, our prejudices about the disease, and the overall lack of action.
You get to be a part of justice being done.
At the same time, Philadelphia misrepresents medical facts, and the producers had to settle a lawsuit with the family of Jeffrey Bowers, an attorney and activist who died from AIDS in 1987 in circumstances that clearly inspired Hanks's character. Even with these missteps, the film elevates this conversation and more voices could be heard. Now, this merely scratches the surface on that, on the struggles and on the triumphs of these films, filmmakers, and their subjects. All of the aforementioned titles belong in your watch list, along with these.
This tragedy, it taught us how to be humble, it taught us how to be honest, it taught us how to love in spite of what's at the end of the tunnel. You know, how to be a little bit more considerate of another person.
For more history downloads and trending tales, stay glued to imdb.com/imdbrief.
So I had planned to tell you about a couple of these movies, and while I was looking them up, I got to that video and I thought, well, that's much better than me trying to talk about it. I hope that you take the opportunity to look at a couple of those if you've never seen them before. Of course, Tom Hanks and Denzel Washington are my heroes. There's a lot of points in those movies that I don't have time to make here today. So 1994, we realized somehow they didn't know that our tissue banks And organ transplants was another way that they could share the HIV virus. And so that became something that they had to look at. 1995. Now, on that very first or second screen, I was talking about opportunistic infections and carcinosarcoma. This is 1995, and we're releasing our first guidelines on how to take care of HIV patients and prevent those infections and treat those infections. Because up until here, every physician was just trying to do their best, but we didn't know what worked. And this is when we started seeing some of our first successes. In 1996, this goes global. This website is still up and running, AIDS.org. It is available in multiple languages, so you want to make sure that you get the /en so that you can view the website in English. So this is a 2020 snapshot from their website showing you what the current numbers are from a global perspective. 1997, this disease on this timeline, you're going to see it swing back and forth on a pendulum. And this is a year of some of our best successes. We have our first big substantial decline in AIDS in the United States. And we think we've done it. We think that it's over, we're curing it. It's all downhill from there. Unfortunately, that wasn't correct. In 1998, this is such a big year. We get our first national treatment guidelines for the use of anti-retroviral therapy. And they refer to this on several of these slides as ART because everybody has a hard time saying anti-retroviral. So we have drugs that work. There's an AIDS epidemic on every continent. We've got Bill Clinton in office, and he's initiating the LIFE initiative to expand efforts to combat AIDS in Africa. And our numbers, look at them, we're reaching 1 million almost of folks in the United States. These are US numbers at the bottoms. For me personally, 1999 marked when my doctors originally told me that it was for sure that I hadn't seroconverted HIV positive. So from 1989 to 1999, they were doing yearly blood tests on myself and my son. Through the 2000s, here we've got the AIDS global, and we're looking at tuberculosis because, of course, if your immune system doesn't work, you can get secondary infections, but you can also get more common infections like tuberculosis because you can't fight that off. And now we start looking at these big strategic plans for how are we going to cure this? In 2002, we get $500 million to prevent mother-child transmissions of HIV. And we're right there, 961,000 folks living with AIDS. This is a current myth. This is published in the African Journal for AIDS Research in 2002, but this is still a thing that they're dealing with in Africa. The myth is that if you're HIV positive and you sexually assault a virgin, that it will cure your AIDS. And so if you still have AIDS, then that means that she wasn't a virgin, so now you have to go find someone younger to rape that's more innocent and pure. So this is a horrible thing. I don't know who started it or where. I couldn't find any information on that, but it still persists to today. This PEPFAR, this President's Emergency Plan for AIDS Relief, this is still a very active program. It started out with $18 billion. And in 2004, it launched in 13 countries. And we've hit the 1 million mark here. And we have 55,400 new infections for 2004. Here, if you fast forward to 2013, we still have this PEPFAR organization doing good things. This was their clinical management guidelines for adolescents who've experienced sexual violence while in a refugee camp or receiving services. 2005, we get our first, January 21st, 2005. This is our first recommendations on how to prevent HIV for non-occupational exposure. So we got the occupational exposure. That's the nurse that gets the needle stick. That's the surgeon in the OR. But now we've got guidelines. This guideline includes sexual assaults. So since 2005, we've had clinical information in place to tell us how to prevent HIV to sexual assault victims. And fast forward to today, and we're still struggling to make this happen every time for every victim of sexual assault. 2006, we start releasing testing guidelines. This is where we're testing all of our pregnant women. We're testing them early in their pregnancy so we can get them on that anti-retroviral therapy if they need it. And then we're testing them at the time of delivery. And so all of that's new. 2008, we're putting $48 billion into the PFER program. It's reauthorized. Now we're including HIV, tuberculosis, and malaria around the world. So this is a big deal. 2009, we look at all these initiatives. We launched this Act Against AIDS. We've got MTV, Staying Alive Foundation. We got the Gates Foundation. All of the big heavy hitters now are on stage and participating. One of the problems, and I tried to find a more relevant article, but one of the problems that we saw happening is that we didn't recognize gay marriages, and the families, as the patient became more ill, would be called to the bedside, and they were allowed to block their partner from coming to the bedside if they chose to. We saw these families that were very disconnected. And then as the patient became so ill that they couldn't voice their preferences, now the parents could come to the bedside and kick the partner out of the room. And so we still see a little bit of this today, but this is where you want to make sure that all of your wishes are very clearly stated. Who you want at your bedside, so no one can take that right away from you when you can't speak for yourself. 2010, we start lifting the travel ban. This is no longer required to come into the United States, that you have to prove that you don't have HIV. These are the red countries, are the countries where you're still not welcome if you're HIV positive. The green, you can travel freely. The yellow and orange, there's some different layers of restrictions. We created the travel ban just to create this false sense of security that this isn't how HIV is transmitted, so it didn't really work to protect us. July 13th, we realized that HIV treatment can prevent the acquisition, and we come up with this pre-exposure prophylaxis. I'm going to talk about this on a couple of different slides. But this, in other countries, what this looks like is your sex workers who have to have a health card to work are getting this pre-exposure prophylaxis. And it's not only preventing them from becoming HIV positive, but it's preventing the people that they come in contact with and they provide services for from becoming HIV positive. Treatment is shown to reduce transmission by nearly 96%. This is such a big number. This is so impressive. You can be HIV positive and not share HIV. We're reducing that transmission with medication. And don't look at the numbers on the bottom of this screen. They're not still in effect. It goes to a different website now. But we're looking at campaigns to stop this spread together. And we're no longer just targeting men who have sex with men or IV drug needles, but we're also targeting women and heterosexual women in our work. So in November, we report, this is that pendulum I was talking to you about, how it swings back and forth. Remember in 97, we thought we were conquering it and we were going to cure it and it was going to go away. Now we see this huge uptick in these 13 to 24-year-olds. They represent 26% because they forgot. They forgot, or they didn't know, or they thought it didn't have anything to do with them, and they don't want to use and how are we getting that across to them? This 26% of our new HIV infections is this very young age group. Sorry, it keeps wanting to stick on me. 2013, we are developing a bilingual Spanish campaign now. We're confirming that the pre-exposure PrEP not only works for sex workers, men who have sex with men, but it also works for people who are injecting drugs. Because remember, we knew really, really early that needles were a problem. And for the first time in 2014, we realized that women who are HIV positive that are on the medication that are suppressing the virus are able to deliver a child and not share the HIV virus with their baby. So I looked at a couple of different videos to share with you guys to talk about what the CD4 count was. And I couldn't pick any of them, but this picture on the bottom right of your screen, that is it in a nutshell. If you are taking your medication, you are suppressing the number of the viral cells that are in your bloodstream, and you have the CD4, these are part of your white blood cells that attack infections that keep you healthy. So if your viral load is high, if your virus isn't suppressed, so that's all those little images under the word viral load, then you can't keep up. You don't have enough white blood cells to attack that infection, and you don't have white blood cells to prevent common infections or opportunistic infections, and you become sick. So that's the difference between being HIV positive and having AIDS. The guy in this, the blue man in this screen on the right is without treatment. He has the virus in his body. And now because his viral load is so high, his immune system can't keep up and he develops AIDS. So hopefully that makes sense without having to go into a bunch of pathophysiology that you might or might not want to listen to. So it goes down to who is virally suppressed and who isn't. And we start realizing that even when people know they have HIV, that they don't stay in care. That becomes a really big problem with people who have the virus and they've never been tested. They don't know they have the virus, so of course they're sharing it. We start looking at outbreaks of hepatitis C and combining and realizing that those are becoming outbreaks of HIV because we're sharing hepatitis C by some type of needle. Unfortunately, when you look down at December 6th, we realize that we're doing good overall, but that when you break it down by minorities and race, that we're actually seeing and so this becomes really frustrating, right? Because why is this still happening? And then we make another very staggering discovery that only 1 in 3 primary care providers have actually even heard of pre-exposure prophylaxis. So if they don't know about it, they're obviously not prescribing it. In February of 2016, we look at the lifetime risk, and then we look at these opportunistic infections. We realize, we start crunching the numbers and we start realizing this pre-exposure prophylaxis could avert 20% of our new cases. That would have a huge impact, right? We realize that we're still not getting it out there with our patients that are sharing needles. We're still failing that. So in 2017, we realized we don't need that grassroots program now. We don't need to mail something out. We need to teach our healthcare providers. And that's what we're doing in August. We're launching a campaign at CDC that teaches healthcare providers how to prescribe the pre-exposure prophylaxis and the post-exposure prophylaxis to prevent new HIV infections. In 2018, we're looking at these studies, and again, we keep breaking it down by race, and we still are not getting this information to our African Americans. We're not getting this to our Hispanic Latino population. And even when these people know that they have HIV, they're not staying in care and suppressing their viral load, which means they can have more symptoms. I love this infographic in the middle here. We diagnose, we treat, we protect, and we respond to clusters. That's it. That's simple, right? And then despite all of this that happens in 2019, that's wonderful. We all know what happened in 2020, right? Everything changed to COVID. They did relaunch their risk reduction tool, and it is amazing. If you don't know anything about the virus and you want to go on there and you want to estimate your personal risk. This is the slide. Take a picture of this, put these phone numbers in your phone. I can't say enough good things about the people who pick up this phone call when you make it. Unfortunately, these lines are no longer 24/7. That's the big downfall with them. In past years, they have been. Hopefully, they will be again. The warm line at the top, advocates, that is the line that your patient can call if they are taking the 28-day post-exposure prophylaxis and something's not going right. Maybe they called their doctor and the doctor's supposed to call them back, but you know, it's taking all day to get that phone call back. The people who answer the phone here can walk them through managing their symptoms, which are mild on the 28-day therapy. The number one symptom they have to deal with is fatigue, gastroenteritis, GI upset, nausea, vomiting, diarrhea. Again, very, very mild in comparison with previous years. This phone number in the middle of the screen is something that my forensic nurse examiners and my healthcare providers, this is what you can call if you have a question about prescribing the post-exposure prophylaxis. When I say the word comorbidities, if I'd said it 2 years ago, you guys might have asked me what it was. Today, everybody knows what comorbidities are because of COVID, and that's so much in the news and in conversation. But maybe your victim of sexual assault has comorbidities and you have questions about how this will interact with medications that they take daily. And this is where you can get those questions answered. Those concerns should not prevent a victim from taking that first dose. I said that at the beginning, and I want to say it again at the bottom. I want that patient to, if this is a concern from this assault, it was high risk, this is something the victim is worried about, and they want to take the first dose. We can change the therapy based on their comorbidities, but we want them to get that first dose as quickly as possible. In the occupational guidelines, like for me at work with a needle stick, that means me taking that first dose within an hour. We know that it's effective for a sexual assault victim to take that first dose within 72 hours. So the closer they are to 72 hours, if they're still not sure, take the first dose and then talk to your doctor. Then decide, maybe then we change the therapy, but don't miss the opportunity to get that first dose. The pre-exposure PEP line, that might be something that you would consider with a victim that is in a point in their life where they're very promiscuous for whatever reason. We know that we see that sometimes. Your sex workers, your IV drug users, anyone that's at high risk or that is sharing needles would need to be on this pre-exposure prophylaxis. So the stigma is still there. Discrimination still occurs. I would like to tell you that it's completely different than it was in the 80s. And I know that most of the time it is. Unfortunately, they still encounter problems. And that's where the support from the advocate can really make a difference. This is the website that I stole the majority of my timeline from. You'll get an email with this link in it also, but if you want to take a picture of that, feel free to. And then I think I have some comments and some questions in the chat. I was trying to look at them. Okay, Angie, the PEP line mentions occupational exposure. Oh, you got it. You saw it yourself. Are therapists able to prescribe for, what are you trying to prescribe, Lauren, for your patients? Can you put that in the chat for me? Oh, thank you, Crystal, for fixing that video link. Oh my goodness, I wasn't in full screen. Anastasia, I'm sorry, I didn't see that when it rolled across.
The Lauren's follow-up, prevention of HIV.
I'm sorry, say that again.
I'm thinking Lauren's asking if therapists can prescribe PrEP, because her response was the prevention of HIV.
Unfortunately, to prescribe in Texas, you have to be, that's like part of your licensure. The website that I recommended. This AETC. Okay, so let's talk about Sydney, let's talk about those separately. For the post-exposure, last one you showed the website link. So for the post-exposure folks, that's 28 days of therapy. So that's 2 pills in the morning or 2 capsules and a capsule in the evening. And generally speaking, with the medications, it's a 3-drug combination. Usually we're using Truvada and Acentris, and Truvada is a combination drug. If you can take Zofran 30 minutes before your dose and plan your day around not being as, skip going to the gym, shorten your work day. For soldiers on active duty, we give them a profile so that they don't have to go to PT. If you're in Iraq or Afghanistan, then you can't go outside the fence. We want to keep you close by so that you can rest. But if they can be coached and supported through those 28 days, then they're done. That's it for talking to them. The toll that it takes on the body, I suspect that if you're talking to somebody who did the 28-day therapy 3 or 4 years ago, they had a very different expectation. These people were bedridden, they were vomiting and diarrhea, they were dehydrated, they were having a lot of additional problems. But with the newer medications, we've really minimized those effects. The pre-exposure prophylaxis, I can't speak to the symptoms as firsthand, but I think with an otherwise healthy lifestyle and a reasonable level of health, that they are able to tolerate it with minimal side effects, because that is just one drug. That's not the combination. Oh, I think Sydney told me I could quit talking about it. All right. What other questions do you have? I'm going to change to this slide. Yes, my son is healthy. He did not seroconvert. I did not seroconvert. It was just scary more than anything else. That's him and his beautiful bride, Brianna, getting married. I have his permission to use his picture. She did make the decision to get married in July a couple of years ago, which meant I had to go outside in the heat in my pretty clothes and sweat like a pig. So until she gives me a grandchild, I'm not going to forgive her for that. But yeah. Oh yeah, huge shout out to the Kind Clinic in Austin for offering both post-exposure and PrEP. So the biggest worry for me is that if your SANE nurse or your forensic program that's doing your sexual assault exam is not giving that first dose, if I tell you in your discharge instructions from the emergency room, oh, call your doctor, make an appointment with your doctor and let them prescribe it, that you're not going to meet that 72-hour time frame. And that's of grave concern to me, because by the time you can call your doctor, get an appointment, get to your doctor's office, chances are very good that you're outside that 72-hour window. And so that's a huge problem. Now they've lost the opportunity to start the medications. And a lot of times, you know, like at day 5, day 6, when I'm still able to collect evidence, like I'm right at 120 hours, you know, the patients are saying that to me, why don't you go ahead and give it to me? And now we're looking at a risk versus benefits. It's like, I think you could have symptoms and I don't think it would work to prevent. Just don't have that many on hand. Okay, so in part 2, this is exactly what we're gonna address, is how to get it. I have been most successful, Beverly, with patients who don't have insurance. If you don't have insurance, Merck and Gilead both have emergency applications, and they allow me to fill those applications out in the emergency room, get the doctor to sign them, get the patient to sign them. And I say that because you can't do it afterwards. And I can get those medications. I can get basically insurance information from one company, and I can call that straight to the pharmacy. So you have to go pick it up. The other company drop ships it to you the next day. And yes, that's a problem when it's a holiday weekend. So what my ER provider can do is write a prescription for the days that you have to wait for the package. And then you only get a couple of pills. So that makes it much less expanded. And yes, Angie, I will absolutely expand on that process. That is what part 2 is going to be about. What are your strategies and what can you work? My pet peeve as a nurse is when I hear other nurses say my pharmacy doesn't carry that medication, which is very concerning to me, because if they have healthcare providers that are taking care of patients, anybody could have a needle stick, and it's an OSHA guideline that they be able to provide that first dose to their employees within an hour. So I don't believe they have it in your hospital. They may not have a lot of it, but they have it in the hospital. My biggest gap has been the patients that have insurance but have bad insurance. So they get the prescriptions and they can't afford to fill them. And so that's where I've been working with my community partners. The link for part 2 should be coming out. Crystal, can you speak to when that will be available?
We haven't set up any links for any January webinars. So those will be coming out at the 1st of the month in January. So everybody who registered for this email got TAASA's general webinar mail out. So be watching for that. It will go out January 5th. And so we will have January webinar links set up in there.
Thank you, Crystal. So one of the things, I thought it would be too long of a webinar. I don't know about you guys, but I can only sit for so long before I lose. So I wanted this part to make you think that to make you feel like it was possible to do something about an HIV infection, and be motivated to want to do something about this for your victims. I'm on the Sexual Assault Survivors Task Force at the governor's office. And one of the things I keep saying to them is that if I, Rebecca, can sit at my hospital and fill out these applications to Merck and Gilead and fax them in and get a response and get free medication for my patients, wouldn't it make more sense for the state of Texas to contact Merck and Gilead and get a contract with them, and then get a pharmacy to partner with, and then make this easier for everybody? Because to be honest, it still takes me over an hour, hour and a half to go through that process, to fill out that paperwork, to get everybody's signatures. Because if I leave one thing blank, it's just like any other application. If you skip anything accidentally or you don't answer it correctly, you have to go back and do it again and refax it. And that just takes more time. But if I can do that individually, that's a lot of work, right? But if I can do that individually, then why do I need nurses in every hospital in the state doing that individually? I want the state to negotiate that for me and make that, skip a step in there and make it a little bit easier. And if you think that would be a good idea, let TAASA know, and then come help me work on that. because it takes a lot of people and a lot of voices to get that heard. For a portion of our sexual assault victims, their sexual assault might be considered low risk, depending on the type of contact that they had. So if it is a low risk sexual assault, then I want to give that victim the power and the opportunity to make that choice for themselves. I talk to my patients about the medications, and then the emergency room physician talks to them about that, because that's actually the person who prescribes it. Any other questions? Thank you, Laura. Yeah. One of my patients, she had insurance, and it was a brand new, I believe Blue Cross and Blue Shield just contracted with CVS. And so they have to get all of their prescriptions from CVS. And so she had to drive out to another surrounding city and get her prescription filled there for one of the medications, and then come back in town and go to the other side of town to get the other one, because none of the CVS pharmacies had both medications. So Pamela, 1996 to 2003. So you saw a lot of this. And I was actually in Fort Worth at that time. I worked at John Peter Smith. That's where I was working when I had my needle stick. Okay, so for the state of Texas, it's no longer 96 hours. For the SANE exam, we go out to 120 now. But yes, that sounds, Freedom House sounds wonderful. Hopefully someday I can go to Weatherford and look at that. So even if they don't, when we say this SANE exam, you have to remember there are two parts to it. It's a medical forensic exam. So that victim of sexual assault could choose just to do the medical part of it and not do the forensic part of it. Or they could choose to do the forensic part of it, but not report to law enforcement if they're 18 to 64. And so sometimes victims just don't know what they want to do, right? They don't know, it's just too much. And we're trying to get them in there in that 72-hour window, and they can't make a decision in 72 hours. And so getting them healthcare and getting them evidence collection that's sent to the DPS. DPS is holding it by statute, by Texas statute for 5 years. But the truth of the matter is that in the statute, it says that they have to be able to notify the victim to destroy it. So they haven't destroyed any kits that have been sent to them because they don't know the best way to contact the victim. And quite frankly, they haven't run out of space yet. So sometimes those are really hard decisions. So just getting them someplace so that they get good health care can be like wonderful. Raquel Nava, thank you. That's sweet. I appreciate your comments. Lisa, thank you very much. It's L-E-S-A, I don't know if I'm saying it right. Any other questions? Crystal, I think I'll hand it back to you.
Okay, all right, thank you everybody. As a reminder, this webinar was recorded for TAASA's YouTube channel. I posted a link in the chat, so please head over to YouTube and subscribe, and these will be uploaded by the end of the year. And I misspoke at the beginning, we have one webinar left for 2020, and then our next round of webinars will start again in January. We will be sending that email out for registration around January 5th. So if you want to receive those emails, please head over to TAASA's webpage and fill out that contact us form. You'll have to scroll down to the bottom under our contact information and just fill that out, and we will add you to our distribution list. So thank you again, everybody, for being here. Great topic, great training today. I'm looking forward to part 2. Like I said, if you need any help with any type of training for your agency specifically or webinars, please contact me, cgarcia@taasa.org. Y'all have a good day.
Thank you so much.